Good morning. So my name is Brian Wells. I'm the co-founder of Four Eyes Insight, and I'm going to lead this morning's presentation where we're going to have a look at an elective recovery program. I have been joined by colleagues from around Four Eyes who are currently working with trusts on their elective recovery program. So I've asked them to join the webinar during the presentation to give some of their personal experiences. I've also got colleagues who are watching out for any questions, challenges, comments you may have. So please do use the chat on the Teams. They're watching out for that and they'll capture those. And then we're going to do, after the presentation, we're going to have a Q&A session where we'll look to answer those questions. If for any reason we miss your question or don't answer it, I've got Hamish, one of our directors, on standby. We're going to pick up those if there's just too many questions, and we'd like to respond via email. We don't want anyone to leave the webinar feeling that they haven't got what they want from it. They haven't heard, they haven't had their questions answered. So please do use the chat. Do give us some encouragement or challenge and questions. That'd be really good. So I think we're going to be talking and presenting for about 20 minutes, maybe 25 minutes, and then we'll go into the Q&A session. Yeah, please get stuck in. Firstly, though, I do want to just take this opportunity to thank colleagues in the NHS for their unfaltering focus and determination to do great things for their patients. We're not just on the sidelines watching in, we're actually engaged with trusts that have been involved through the full challenges of managing through COVID. I've been in contact with clinicians and managers through this process and experienced the determination and focus of teams to do the best they can do. It's massively admirable. So I just want to take the opportunity to thank you all for that. But also just, from a starting position, it's just such a monumental effort. And we are now going in yet again into a whole new environment that everybody is learning from, including Four Eyes. So we want to share our experiences, our ideas, what we think is the right direction of travel. Do challenge it and do take the good bits that you think are helpful. So on that, let's get started. I'm going to go off camera for the presentation, but I'll come back up on camera, and so will my colleagues when we get to the Q&A section. But just to make sure that we don't lose transmission, I'll go off camera just during the talk. So the agenda for the session, I'm going to talk a little bit about Four Eyes, just a little bit about what we're doing currently. I want to give some context of where we currently are with COVID. There is an awful lot of information out there and a lot of press coverage, as you can appreciate, is the only thing that's pretty much discussed on the news. So I just want to bring some context to where we are with COVID. Then I want to just discuss some of the significant planning challenges that organisations, systems have to consider if they are starting to look at kickstarting an elective recovery programme. But there's also some significant opportunities. So as much as some of the challenges and the difficulties, there have been some great opportunities coming through this that I want to share with you. And then I want to go into a section where I share our thoughts on the structures and activities of an elective recovery programme. What do we think is the best route to starting this? It's the wood for the tree stuff. How do you start off on that journey and then escalate your capability? And then we're going to move into a Q&A section where I'm really looking forward to me and the team trying to respond to some of the questions as you push them in. I think it's important to acknowledge that this is a new challenge for us all, but the core focus of Four Eyes has always been to measure, report and help deliver productivity programs across elective pathways. We've worked with a large number of NHS organisations and we've always been in pursuit of operational and productivity improvements, and in most of our work it's been involved around the elective pathways. Even now, we're working with organisations that are planning and launching elective recovery programs. So we have people in the front line working alongside managers and clinicians in planning and preparing for elective recovery. Therefore, we hope that our significant experience over the last 8 years of working around elective programs, and also our most recent experience of working with trusts in redesigning the focus around elective care with COVID in the backdrop. We hope that those experiences and the advice that we bring into this webinar adds value to you guys as you go about your business trying to develop and deliver your elective recovery. I'm certain you're all acutely familiar with the reported impact of COVID-19 and the challenges that it raises for the NHS. This pandemic has massively disrupted the elective pathways, even for those most vulnerable cancer pathways. We've all seen reported news about A&E attendances that have dropped, with some analysis suggesting by over half normal pre-COVID attendances. Yet we are aware that many patients out there need to attend A&E. You know, there's stroke patients, cardiology patients, etc., that are staying away from hospital. We've also seen a significant scaling back of outpatient consultations, and a lot of it's gone to virtual, but there's also been a huge amount of capacity that's been taken offline. There have been significant concerns over PPE. This has been well reported, staffing, equipment, and facilities, but even now, amongst all of that, the NHS is having to plan for yet another potential COVID outbreak, or peak, sorry, another peak. So the NHS has a new normal to consider. What's always been a complex process, basically that of delivering timely and efficient elective care, has become a lot more complex. The NHS remains at level 4 national incident, and all the coordination and control that entails. It is thought that COVID is going to be with us for some time, with the challenge of working in full infection prevention and control environments with significant changes to patient pathways and cohorting. And the need to widen testing and consider the challenges of isolation, social distancing processes along the elective pathways has just made elective care much more complex. Trusts have received a letter from Sir Simon Stevens and Amanda Pritchard around basically the challenges that they need to consider during this second phase response to COVID. And there are some key challenges that I've listed in this slide here. So therefore, organisations are needing to prepare for a reversal in the recent reduction in emergency activity, some estimates up to 65%. Organisations have got to consider their capacity requirements post-surge capacity, such as the Nightingale hospitals, private sector, etc. These need to be considered alongside future COVID demand and pandemics. There needs to be an immediate need to quantify the size and waiting times of the elective pathway backlog at system ICS level. We know that there is a huge amount of activity on those elective waiting lists that have sat dormant now for a number of weeks, and therefore the numbers are only going to increase, and there needs to be a real understanding of the size and the priority of the activity on that waiting list. There also needs to be a step up of non-COVID urgent services, including providing urgent outpatients and diagnostic appointments, and ensuring that urgent and time-critical surgery can be provided at pre-COVID levels of capacity. And that's a significant challenge for organisations to think about. There needs to be planning for and starting routine non-urgent elective care segregated away from COVID patients. There's also challenges around infrastructure and facility changes. There's a requirement now to permanently increase ICU facilities and capability, and potentially organisations need to consider increasing their laminar flow capability in theatres, etc. There's likely to be potentially permanent changes in remote working and virtual clinic consultations. And so therefore, there's an opportunity to understand and review how we use the space that remains within hospitals. And then there needs to be a significant focus on the availability of staffing, medicines, PPE, bloods, consumables, equipment, etc., etc. So there is a significant challenge here in this second phase of response that trusts are looking to answer. There are opportunities, though, to improve performance and create a more agile and resilient NHS. Optimal elective recovery needs to be steered at a system level, and in that I'm talking about ICS and STPs, who will need to take the lead by working with primary care to support referral processes, including demand management and the championing of the use of new technologies. Systems need to capture those pathway changes that best serves their patients in the new normal. Mental health need to manage the repercussions of COVID for NHS staff and patients, and community services will need to continue to support improved discharge processes. And a big challenge here is the NHS working with local authorities to better integrate care homes and support more effective discharge arrangements. But ICS and STPs can also help across systems with the sharing of equipment, ventilators, supplies, medicines, PPE, etc., through mutual aid arrangements to actually facilitate this activity in hospitals taking place. Okay, so that's really setting the scene and the size of the challenge. At this stage, I'm really keen to engage colleagues that have been working alongside our NHS colleagues within frontline services, and I've asked them to share some of the learning coming out of working with trusts and systems. So on that, I'm going to ask Graham to share his thoughts around his experiences on virtual pathways. Graham.
Thank you, Brian. Good morning. We're currently working with the Trust to support elective recovery, and along with all other organisations, outpatient appointments have been reviewed and placed in priority cohorts in line with the Royal College of Surgeons guidelines. As you'll be aware, the majority of face-to-face appointments have been converted to virtual activity. Some patients will still need to have face-to-face appointments, predominantly these who need a physical examination or a biopsy. And there are also other cohorts, including patients for safeguarding and breaking bad news. What we've also looked at is all specialty pathways to be reviewed and remapped, linking this into primary care and CCGs to ensure appropriate governance is in place. Along with this, we've received clinician feedback via a questionnaire. From the results received to date, for new appointments, indicative figures of 30 to 50% could be virtual, but this is dependent on the type of service. And follow-up, indicative figures are around 70 to 90% could be virtual, again, depending on the type of service, but with support from nursing and therapy colleagues. Initial patient feedback is positive. They're finding this much more beneficial for parking, for not having to take time out, long time waiting times on site. And also they know that if somebody's going to ring them or it's a video, it's a certain time that call is going to take place, so they can plan their day better. We've also looked at junior doctor training. Consultants are suggesting that virtual could offer additional training opportunities, particularly for video appointments. But overall, they're suggesting that virtual will be the way forward. Triage and setting expectations early with both patients and primary care practitioners are vital to supporting the changing face of healthcare. Thank you.
Thanks for that, Graham. I've also asked Alex now to offer up his experiences around optimising the best use of capacity. Alex.
Yes, thanks, Brian, and morning, everyone. So we're seeing changes around what optimal use of theatre capacity looks like. So through the peak phase of COVID, the focus was very much on the category 1 and 2 urgent cases being treated. And the likely next steps now are bringing back in the category 3 and 4 patients and the long waiters, with a return to looking at parts of utilisation and performance that were around before COVID. So in the planning groups that we've been supporting, some of the operational teams are actually already trying to do this. So teams are identifying available capacity or low utilisation on lists, and that's indicating that some parts of recovery could be turned on earlier than expected. There have been challenges though in making that happen. So the first big one is that the clinical risk of filling lists to optimum still remains. So things like the time needed to don and doff PPE, or concerns over the volume of patients moving through the department, those risks still remain. And secondly, there may be some regional or hospital site mandates that are still in place. So for example, only treating risk stratified 1 and 2 patients on certain sites. So I think more than anything, we've learned that there needs to be a robust escalation of any available capacity at every stage. So whether it be through your existing silver and gold structures or through regional hubs, people need to know what capacity is available and work through the reasons why that isn't being used to optimum. Some of those reasons will be justified, but I think working through them collectively will be able to maximise the recovery plans at the earliest opportunity.
Thanks, Alex. Thanks for that. Then I've asked Tom, one of our directors in 4eyes, to join us and provide his thoughts on working within a system response. Tom.
Thanks, Brian. So yeah, at a system level, there's a few things I want to mention. So it's important that we recognise that coordinating a COVID incident response with a command structure across a system with multiple organisations and stakeholders is time intensive, and it does require considerable resource. However, if it's done well, it can be hugely helpful to make sure we maximise the use of system capacity, things like theatres, critical care, the independent sector, testing capacity, and also to support mutual aid for things like equipment, supplies and PPE. Also, whilst everyone across the system is working hard to a shared common goal, some of the pre-existing divides between health and social care have been exacerbated during incident response. And of course, recovery and restoration provides potentially a unique opportunity to be able to resolve some of these systemic issues, working through some of these things now with organisations. Managing and responding to the different communication demands, the templates, returns from HSI and E regionally and nationally is a challenge, and Brian mentioned the most recent letter earlier in the presentation. But look, it's important to recognise that assurance is an important thing. It's important to recognise that managing the work regionally and nationally is a huge ask, and of course, using these tasks to frame and focus the local work that's been undertaken it can be really helpful, and we provide a lot of support around making sure that's as slick and as value adding as possible. And finally, all health and social care leadership teams are working flat out, responding to this ongoing incident, and may need additional support structures, different ways of working to make sure that that's sustainable. And as we move into recovery, it's important more now than ever, really, that we get this right.
Thanks, Tom. Thanks for that. That's great, guys. Thank you for your contribution. And these guys are going to be around at the end of this. I've got a few more slides to go just to respond to any questions and answers that come through. So do send your messages through on the chat. So the challenges have been identified. So where do you start? So in this slide, we've pulled together our current thinking on the key activities that need to be considered when embarking on an elective recovery programme. We believe a phased approach will be more manageable, with the first phase undertaking a current state review and readiness assessment to identify the priority actions for starting an elective recovery programme. So if you're looking at this slide here and looking on the left-hand side of your screen, you've got phase 1. We think that, okay, we've put some timescales on this, but actually more important is the content, which is a current state review and readiness assessment of where you are in your journey in planning elective recovery program around theatres, outpatients and diagnostics. And what we're looking for here is a real, quite raw, honest assessment to the executive of what operational reality is. So you've got a few things inside the box beneath which just start to demonstrate the kind of things that need to happen. So the priority number one, absolutely understanding, is the risk stratification and prioritisation of the waiting lists of the PTLs, the admitted and the non-admitted PTLs, at specialty level, subspecialty level, and you know, right down to clinician level, just understanding the risk prioritisation on those lists, and actually securing clinical sign-off on that, so that the organisation has a very clear understanding of what its priority 1s through to 4s, 5 patients are, and that information is visible. So what our experiences are is that there is quite a lot of this risk stratification going on in department level, on spreadsheets locally, you know, quite a low level. And what's really important is to have this at both, certainly at the executive level and even possibly at system level, where there's real transparency about the activity on those PTLs and the prioritisation of those patients on those PTLs. The essential thing here is, and we know that there's 4 or 5 PTLs actually, and it's making sure that patients are not dropped between the assessments, so no patient gets missed. Then there's a real understanding of the current status of pathways. Pathways will change and have changed and will have to change going forward. This is the new normal. We're living with COVID, and even if we are testing, we're still ultimately living in an environment of risk around COVID, and therefore pathways, as you'll appreciate, elective pathways are going to change. So again, mapping out those pathways at specialty and subspecialty level across the organisation is absolutely critical, and it's even more complex if you have multiple sites. So therefore, having that understood, again, transparent and obvious to all, is really important. And then there's a readiness review around theatres, outpatients, diagnostics itself. As we're all really aware that you know, quite a bit of those facilities, certainly around theatres and diagnostics, has been heavily loaded towards COVID support, and rightly so. So you know, we've got enhanced ITU, recovery being used as ITU, we've got theatres being used as ITU, and all of the staff, you know, associated to those areas also supporting the work in ITU. So therefore, an understanding of what capacity is truly available to support an elective programme for those first urgent cases, your priority 2s, because your priority 1s, A's and B's, are generally being dealt with through the CPOD and trauma processes. But this is your priority 2s, you know, patients that are waiting up to 4 weeks or around that period, and even potentially your priority 3s up to 3 months. You know, what resources have you got available? You know, potentially what clean sites have you got versus, so green sites versus red sites, green pathways versus red pathways, etc. So mapping that out and having a good understanding of that before you launch into a wider elective programme is really important. And then, as you'd expect, you want to understand that you do have a good governance process in place. Currently, you know, organisations are daily managing a lot of this through the gold command structures. You know, our view, the board wants assurance over these pathways and risk stratification and the launch of elective programs. So it would be very, you know, it would be a good idea to have an elective recovery board that reports into the executive structures or the gold command, and underneath that, the associated and necessary task and finish groups being launched in order to deal with any of the challenges, the bottlenecks that are going to cause problems for launching an elective recovery program. And then obviously having your action logging and your outputs from that through the task and finish groups. So we feel that's a ready state assessment of that whole process. That's the first thing that needs to happen. And then you move into phase 2. And phase 2 really is about implementation requirements across those 3 areas of outpatients, diagnostics and theatres. All three are intrinsically linked, and so they need to be launched in unison. The process needs to be dynamic in its ability to stand up and stand down the programme in response to COVID and any potentially future surges. But within that implementation programme, is the opportunity to, and there might be seamless, you might just move very, very seamlessly from phase 1 into phase 2, but it's about resolving those identified blockers before you start your elective programme so that the whole pathway is able to move in the right direction. And then you need to implement the revised reporting suite and potentially model alternative scenarios. We know that theatre capacity will have changed. Capacity will have changed, activity on waiting lists will change through validation, etc. So the whole modelling around that's going to need to change. And then we need to embed the ongoing process for risk stratification and patient prioritisation. What we say on that is that it's not a single point of effort, that it should be a continuous dynamic process. Patients on those waiting lists, their conditions are changing constantly, and therefore identifying the most vulnerable and priority need patients first is critical. And then get on and implement revised pathways. So we've put that into a phase 2 piece, but it's a seamless thing. Risk stratification, pathway, understanding the pathways, putting the governance structures in place, and then resolve the blockers and move forward into implementation. And then we've got a third phase here, which is really important, but sometimes not there right in the forefront of when you're deep in the operational launch and planning of any kind of process, but also the elective recovery programme, which is locking in some of those amazing transformational things that you're experiencing through your organisations as business as usual. Along with that, so for example, there's going to be all sorts of things that will need to happen, which is longer demand management solutions, the pathways to roll out the virtual pathways, right? There's going to be a real need to capacity around right sizing your outpatient theatres, endoscopy modelling, etc. We are witnessing and experiencing significant changes in capacity. So, for example, laminar flow theatres are an incredibly valuable asset in an aerosol disease such as COVID-19, and therefore, the priority use of laminar flow has changed quite dramatically. So, therefore, we're seeing it, the laminar flow that is being used for endoscopy, for example, which are high-risk procedures because of the aerosol emitting processes within those procedures. And therefore, the priority use of laminar flow theatre has changed, but also the capacity within those sessions. So what we do know in non-laminar flow theatres, for example, the endoscopy where they may have done up to 12 cases in a session, may be doing around 4. And that might be greater in laminar flow because of the air changes. But the point is that capacity will have changed dramatically in this new the new ways of working rather than pre-COVID. So the assessment of that and understanding of what the capacity is really important. The same thing with radiology. The radiology is and most of the diagnostics are serving across a very complex arena at this time. So capacity in radiology is going to be significantly challenged in this process. And then the final bit on this is locking in those sustainable changes so that it becomes sustainable. So those virtual clinics, those transformational changes, the reporting mechanism, the new pathways, locking these in as business as usual going forward, and making sure that the operational processes around it are sustainable. So this is the sort of this is our layout, sort of banner of what we think an elective recovery approach should consider. Clearly there will be variations. It needs to be quite dynamic. It needs to be dynamic because of where the organisation is at the time. Some organisations are further to the right than others. But ultimately these are the sort of things that organisations need to address, consider and have in place before they launch an elective recovery programme. And I'll be interested in your feedback on that and whether you feel anything is missing or you feel that this has hit it right on the nail. Risk stratification and patient prioritisation is a critical and essential starter of any elective recovery programme. Ensuring all patients waiting on a dormant PTL are cohorted and risk stratified will ensure the most urgent cases are identified and treated first. We all know that the task is challenging. There's good advice on cohorting out there, such as the Royal College of Surgeons stratification at procedure level as a starting point. They've issued some guidance, which is guidance, but it's really good. It's incredibly helpful because it lists in buckets by specialty those procedures that it determines are the most riskiest through a priority level of 1 through to 4, and that's a really helpful starting point. And in fact, so we've been looking at that in some detail. So risk stratification needs to be seen as dynamic and continuous rather than a single point of effort. And it's here where software can be of assistance. 4eyes, so we're currently, in response to COVID, we're currently developing software to support risk stratification. And this is really in a need to reduce the need for heavy lifting. And what I mean by heavy lifting is that whole process of individual departments and Excel spreadsheets and disconnected PTLs looking to risk stratify. What a trust executive wants is the assurance that all patients have been universally risk stratified and are captured in some waiting list. And our belief is that software can certainly help in that arena, and it can also help faster pace that. So software can help. So in summary, we just need to make sure that there is certainty that organisations are treating the right people at the right time in the right location. It's an easy statement to make. It's going to be quite operationally challenging to deliver. As routine services are brought back online, there needs to be a focus on the elective pathways, as a whole, with the intent to open up blockages, not creating bottlenecks. We have seen a massive can-do attitude across the NHS. The same kind of energy is going to need to be focused on elective pathways if they're to be successful. We need to look at how you use your core capacity more effectively. Both clinicians and the facilities are a finite resource. And as I've just described, the capacity is going to change and will have changed quite dramatically. And therefore, this limited resource is precious and needs to be used as optimally and safely as possible. We need to ensure that the transformation that has occurred and is still occurring is sustainable, is valued by patients, and is locked in to your pathways and your processes around elective recovery going forward. So we need to use this opportunity to change things both within and outside the provider trusts, committing to the innovation and those positive transformational changes at a system level, because such transformational change is vital. So that's the end of the presentation element of this. So we've raised the challenge, we've suggested what elective recovery programs should look like, and the need not to lose some of that real fantastic transformational stuff that's going on. And on that then, I'm going to now hand over to Hamish, one of our directors in the company, who's going to facilitate the Q&A section. So Hamish, over to you.
Right, many thanks for that informative presentation. We have a number of questions. I'm going to propose that for the Q&A section of the webinar that we ask a number of our subject matter experts to field these questions. First question relates to outpatients. How would you propose getting back to a pre-COVID state in outpatients?
Thanks, Hamish. Hello, everyone. Well, in a way, I don't think that we should be looking to get back to a pre-COVID state in outpatients. Yes, that we do need to drive volumes through the system and work in a different way, but there is a real opportunity to harness the changes and change in practice that's rapidly taken place. For all those that have worked in outpatients, it's been quite an uphill slog to get transformational change in outpatients. So to have so many patients now being seen virtually, to have pathways being redesigned, it is a real opportunity. However, there is significant volumes of routine patients waiting, and some of them may be urgent or moving into an urgent state. And there certainly is a lot of patients that will be moving to over 52 weeks of waiting. So what I'd recommend is that, as Brian was saying, is setting up that structure in place with steering groups and task and finish groups, and actually getting into the detail of current situation. So what has happened, what patients are waiting, and what issues and barriers are in place. Because like theatres, there needs to be hot and cold areas set up. You've got all the estates issues around that, and staff availability, equipment and so forth we need to know what the current situation is, and then we can then start planning for how we can roll out more outpatient services. So that is about risk stratification. So I know some patients are being seen, they're being seen face to face, but it's getting a sort of robust, systematic approach in place that is something that can be used and should be an ongoing process. And for me, one of the key things is about how to reduce the size of your waiting list safely, to free up capacity, embrace technology and change pathways. So in sort of a recovery situation, it will be about PTL tracking, modelling, and then looking at what your current capacity is and making sure, one, that has to be optimised, but it's also about improving pathways. So some have already been done, and with staff going into rapid contingency mode, there needs to be a formalisation and standardisation of virtual pathways, of other pathways that have been put in place to make sure that there is a robust governance. A lot of IG would need to come back in place just to make sure things have been done correctly. But for me, it will be about reducing avoidable appointments is going to be key to releasing capacity. And absolutely prime now will be moving and gearing up to improve or launch or continue to launch patient-initiated follow-ups, especially for post-surgery and long-term conditions, which is a really good place to start. It's also about looking at the whole system, and I think now there is a really good opportunity to work at a systems level to improve triages coming into trusts, and how information, how referrals are moving across the trust, consultant to consultant referrals, etc. So lots to do, very tricky, especially when it's dependent on each trust and where they are on the journey, and there's so many variables there. But it's something that it's about planning and working together as a team. I hope that answers your question.
Great, Kathy, thank you. Kathy's our outpatient lead, and I thought it was a very clear response. Next question relates to theatres, and in particular the utilisation of theatre capacity. I'd like to invite Cherry Lee to field this question. Cherry, the question is, utilisation of theatre capacity is being negatively affected at this time, as we know. From your experience of working with trusts in the environment over the past several weeks, what do they need to think about doing concerning planning and utilisation over the coming months?
Yeah, thanks, Hamish. So utilisation of theatre capacity has been affected several different ways. One is the redistribution of workforce elsewhere to support ITU and the like. As those members of staff come back to their parent department and they're back into theatre, and there is capacity to operate, there is an underlying fear of bringing patients who do not sit in those category 1As, 1Bs and 2s into a department where there is a risk of cross-contamination of COVID. And that's quite understandable. However, patients are going to have to start coming through more elective pathways and prioritising those patients to make sure we get the right patient at the right time in the right place is going to be key. So this comes back to risk stratification and cohorting of patients. This also leads to a process needing to be implemented to manage a PTL along those lines. So patients that have originally sat as a category 3, for example, if they remain as a category 3 for a period of time, a process of reviewing those patients to determine whether they have been bumped up to a category 2, maybe because they've suddenly become a long waiter or acutely unwell. That will be really key to making sure that if capacity is available, we are bringing the most urgent patients in order, but also making note of patients who are tipping over, and then utilising capacity effectively that way. Another key ingredient to getting capacity up and running will be clinical engagement. That's both clinicians, surgeons, anaesthetists and nursing workforce, as well as operational teams who are looking after scheduling and managing those patient pathways. This engagement will not only give the clinicians and the teams working on the ground more confidence to work in those environments, so consulting on PPE availability, pathways, health and safety, infection prevention, getting those SOPs locked in with clinical sign-off is going to be key for that confidence, but also for the portrayal of that confidence to our patients. So patients have been feeling nervous, quite rightly, because of everything that's been said on the news, that coming out of their homes and into a hospital department may well put them at risk. And so if we have an ethos within the teams working in theatres that actually the processes are in place to mitigate against that risk, and then that will pass on to patients who'll be more likely to take up their appointments and come into hospital. Another thing to look at, and Kathy referred to from an outpatient's point of view, is looking at hot and cold sites or hot and cold departments or elements of departments that can be deemed cold or red and green. And this will all be led by the availability of such departments, but also the teams working in them, the pathways that are developed, and those cohorts of patients and which patients go where. So it comes back to right patient, right time, right place. Another element that's going to be really important, and this is going to be for the long term, is looking at how we're going to test patients. So swabbing and testing and isolation policies post-swab are going to be key, not only for confidence, so we are confident that we're bringing patients through who have tested negative and self-isolated into cold sites, so they remain cold. But also that it fits into that pre-assessment pathway, and pre-assessment notoriously is a blocker to good utilisation in theatre, mainly due to the different natures of patient optimisation. So different patients on different pathways can become tricky, but also a demand and capacity issue, and demand on pre-assessment and patient optimisation, including testing now, is going to become really key to making sure that you have the right cohorted patients ready for theatre so they can come through when that capacity opens up. And finally, and it's something that we would look at in a non-COVID time also, 642 and scheduling. So that planning of your capacity, opening up capacity in line with demand and looking as far out as possible. So we would normally look at 6 weeks out, planning down to 2, and then scheduling week 0 to 2 to make sure we're utilising capacity. This would be a revised 642 in line with new practices. So taking into account the fact that there are new infection prevention controls in place. Different theatres will be working towards slightly different guidelines, but the scheduling policy must work towards that. So looking at the monitoring in line with 20-minute turnarounds and the like. But I really think the methodology behind 642 and scheduling is going to allow for not only a structured stand-up approach, a standing up activity again, but also if a second wave was to come upon us, or even winter pressures, which are going to land at some point, it'll allow for a very systematic stand down. So for me, they're the key areas that would need to be focused on to get elective capacity back up and running and good utilisation through theatres.
Fulsome response.
Cherry, just a quick one on I was analysing, because we do the data analysis for the National Theatre Productivity Review for the nation, and actually looking at that, about 70% of the activity on on that data are general anaesthetic cases over LA cases. And obviously, with the high risks, the high risk procedures that are identified under COVID is intubation and extubation, so under GA. So that's going to raise a significant challenge on elective recovery program, because if we look at history, then 70% of patients by default are going, if we don't change things, are going to come through and require general anaesthetic. But how do you think the elective pathway is going to have to consider things like that?
Yeah, I mean, I think it's quite an exciting time, actually. The unfortunate events have actually led us into a position where transformation of patient pathways is going to be available. And I think looking at local and regional block lists, which not only will give patients better outcomes, discharge patients quicker, less time in hospital, but I think that will also lead in to utilisation of theatres, because we'll be able to run more patients through under local and regional lists as opposed to GAs. So I think this is really a sort of silver lining, is being able to work on those transformation programmes to fit in line with trying to improve utilisation, but also improve patient pathways and outcomes. So I think it'll be really exciting, actually. And
also, we don't know the numbers on this, but it is something that I'm really keen that we understand this. We estimate that probably, and it's a probably, but looking at the average trust, less than 30% of theatre stock and flow. Is that so important? Because we've got obviously operating theatres and then we've got laminar flow operating theatres. Why are we talking about laminar flow? Why has that become quite a challenging area in this to be considered in the pathways?
Yeah, I mean, I think you touched upon this earlier, looking at the infection prevention element. So the quicker turnaround through a canopied theatre are far more frequent than a non-canopied theatre, a non-laminar flow theatre, and this normally would be assigned for joint replacements and the like, because of the evidence behind reducing surgical site infections and so on. And so now those units are being used for the more aerosol producing procedures, so they're being taken up. The other side of it is looking at utilisation. So the turnaround time between cases, the advice, the guidelines at the minute is non-laminar theatre around 20 minutes, depending on air changes. That's halved under a laminar canopy, which will allow for scheduling more lists and greater utilisation. So your turnaround is reduced. So there is going to be a lot of questions around appropriate estate and developing theatre departments that will incorporate more laminar units. I would think that's going to become a real key priority.
Yeah, I agree. Thanks, Jerry. Thanks for that.
Great, thank you both. We've got a question on diagnostics. I'd like to ask James Davis, our diagnostic lead, to respond, please. The question is, diagnostic service capacity continues to be negatively impacted by the pandemic. This is a particular concern with regard to diagnosing cancers and other time-sensitive conditions. What should Trust's priorities be during an improvement programme?
Hi, thanks, Hamish. Good morning, everyone. A comprehensive assessment of your waiting list would need to be undertaken in the first instance, completed for each diagnostic specialty, which would also be split by clinical urgency to understand exactly where you are as an organisation. This will be the foundation to restarting diagnostic services. This will lead on to establishing and agreeing a key patient prioritisation strategy for each specialty. To do this, clinical engagement is absolutely key and will be based on strict referral criteria. Organisations will then need to undertake a multidisciplinary approach to agreeing list capacity and list design. This would take into account the current guidelines and challenges around PPE, infection prevention and control, and social distancing, as well as those set out by key organisations such as the British Society of Gastroenterology, thinking of endoscopy, and the Royal College of Radiologists, thinking of radiology and imaging departments. Just as an example, organisations need to think very carefully about aerosol generating procedures in endoscopy. So gastroscopies is what I'm thinking of, and how we manage capacity in those lists as safely and as efficiently as we can. So once your new list templates are redesigned, a recovery program would then move into more familiar territory to many of you, of using a scheduling and 642 meeting on a weekly basis to help right size lists and place priority patients appropriately using an enhanced floor plan. This will ensure that patient prioritization or risk stratification, if we want to call it that, and design of lists are dynamic and that they are being reviewed on a weekly basis. And in addition, as we've heard from some of the other answers, there is opportunity to make some long-term transformational changes as a result of a new normal in diagnostics. And this is very much an opportunity that we should all be embracing. Thanks, Hamish. I hope that answers it.
Very comprehensive, James. Thank you. I've got a question now related to AGPs. How are trusts managing the 20 minutes either side of each patient relating to AGPs? This is obviously an issue. Brian?
Yeah, I think I don't know if Cherry can support me on this, and Graham on the call, but you know, are we talking about the air changes in laminar flow at 20 minutes, the stand down periods?
Yes.
Yeah. So I think so. The risk in this is that theatres and the movement of activity through theatres is seen in a linear process, whereas what we do know is that there are multiple things happening at any one time. And what one has to understand from the downtime between cases is what's the capability of the clean air theatres. So what we understand from the published data, from the published guidance, is that it takes 5 air changes to reduce any aerosol risk contamination down to less than 1%. So I think a standard theatre, we're not sure, but Cherry or Graham, I think it's about 20 changes per hour or something. So it takes, and that's where the 20 minutes came from, was that, you know, in a standard theatre it's going to take 5 complete air changes to take any aerosol risk down. So therefore, ultimately, you need to clean theatres, shut the doors and let the air change over. Laminar flow changes that quite dramatically, because the air changes in laminar flow, and they differ between all laminar flow type of products in use, but actually, you know, is much quicker, and therefore the downtime that you have to close the theatre and allow for the air change to take place is much shorter. But that doesn't necessarily mean that there can't be other further preparation processes going on at the similar time. So therefore, to reduce that downtime as much as possible. The risk here is that there is a huge amount of downtime that's applied, and therefore, you know, productivity or the ability to do more cases is actually affected adversely, quite dramatically, by the fact that people are applying too much downtime. So the important thing here is to understand, you know, and this is where the estate's engineers and everybody else should be involved, which is what is the actual air changes and the time for those air changes in the operating theatres for those organisations. And the maths is straightforward on the back of that, and allow for those air changes between cases and the time that's required for that, rather than some arbitrary 45 minutes, etc., etc. I think you know, the science is there. People should follow that guidance. Cherry, have you got Graham?
Yeah, just as well as all of that, and I think it's really important that individual trusts and individual departments, based on their estate, get that timing right and agreed. But actually, the flow of the patient is going to become really important, and the process, so the perioperative process, and the review of that. So again, it comes back to this opportunity for transformation. How actually are we walking patients through theatre nowadays? Because this gap between cases and air changes, this isn't going to go away anytime soon. This is going to become the new normal. And rather than just accept that we're going to lose capacity, I think new ways of working are going to really come into play here.
Thanks, both. We've got a related question, which is, do you have thoughts on the issues associated with the need to test patients prior to admission, as this may well introduce a further lost capacity depending on how it's managed?
Yeah, I mean, there's discussions going on about extending testing for all patients preoperatively at pre-assessment. But obviously then there's a need for them to go into isolation prior to arrival to hospital. Obviously there's a big debate about this because clinicians currently today aren't necessarily assured that those patients aren't still a COVID risk. Some of our people have experienced that is the case. Therefore, as would be right for most clinical teams, they're going to err on the side of precaution. And therefore are most likely to continue to follow infection prevention and control through the process, irrespective of testing. But speaking to some clinicians, they're saying testing 48 hours out patient isolation, that de-risks it. If you're using clean air theatres, that de-risks it further. But there's lots of guidance on that on the NHSE website around this. Cherry, Graham, have you got anything else to add on that?
Yeah, it's probably my voice again. So as well as testing, and although testing is around, you can get your test back within 24 hours, it's actually the policy of monitoring those patients post-test before they come in is going to really be key. So that policy around, once your patient's been tested either in the community or they've come into the department for testing, what's the advice for that patient before they walk through your department doors? That's going to be the bit that will maintain the safety of the patients, but also the cold nature of that department, or the green nature of that department.
Another point on that as well is that Cherry mentioned that quite a few organisations have gone into cold sites. So what's also happening with those, and we've got an example of an organisation where we've worked. They've produced a mini hospital with its separate entrance. But what's also happening is that the staff are being tested as well, and it's the staff within that department only work in that department. They don't go anywhere else at all. But the other thing that's impacting that they found is their recovery nurses are still in ICU, so they've had to put urgent training programs in with their other staff that are left, because obviously they're not running as many theatres, to get the recovery teams back up and running as the patients are being discharged from critical care and allowing their patients to come back. It is very, very fluid at the moment, and it's a huge challenge for the theatre teams.
Thank you all. Thanks, Graham. We've got a couple of questions that are related to the challenge that is staff fatigue when refocusing on the restart. And Alex Jackson asked, staffing will become an issue with increasing workload. Breaks are difficult to work into the lists whilst maintaining efficient patient flow. Give some thoughts on that, guys.
Yeah, I've got initial thoughts. So we're looking to monitor this, and I mean this in a really positive way, so that there isn't an overstatement of the opportunity. But interestingly, only this week, internally with our development team and analysts, we're looking at how you measure list breaks versus downtime, because as you'll know from the National Theatre Dashboard, we have intercase downtime that we measure as part of the opportunity. We need to really, so we're developing that much further going forward, so that we can really understand what's a list break and what's intercase downtime, because currently the data would combine the two unless we absolutely knew there was a list break. And as you'll appreciate with list breaks, it's an easy thing to say that assume everyone has a list break, but the reality is very different. And pre-COVID, it was definitely very different. Some clinicians did list breaks, some clinicians didn't, some specialties did, some didn't. So it was a very, very mixed bag. So we need to understand that. And obviously, I absolutely get that with staff fatigue. They are going to need to have, especially with the fact that they're going to be wearing a lot more PPE than they've ever done before in an elective programme, that they are, lists are going to have to consider downtime for staff to refresh themselves and take a break, especially if it's an all-day list. And maybe this is a challenge around all-day lists. Maybe the fatigue won't allow for all-day lists for some specialties, and that we are into half-day lists much more. Those are the kind of things that are going to need to be planned through the demand to capacity piece, which is what is a reasonable amount of activity and what's a reasonable amount of expectation in the work effort of the staff in those operating lists. And I think that's a journey everyone's going on. So I think you're going to have to test and check and challenge on that.
Thanks, Brian.
Cherry, Graham, have you got any other views on that?
Can I just come in there, Hamish, James? Just to say, really a great place to do that check and challenge that Brian mentioned is your weekly 642 and scheduling meeting. That really is the place to have that initial conversation about, how long cases are likely to take, what staff you need in there, and working in breaks well in advance to the list with some intelligence, so that you can right size the staff on the ground.
Yeah,
great. I've got a question from Jonathan Coe, who asks, have we worked up a dynamic method which can ensure that risk stratification is live rather than a one-off event which quickly becomes outdated?
Yeah, that's a really good question, actually. Yeah, I love that question, because ultimately that's the biggest challenge, which is how do you do dynamic risk stratification rather than a one-off event? And I sort of said in the talk a couple of times that is a significant challenge. So we have rapidly moved forward. I'm just saying this because I'm sure there'll be other tools out there as well. But because we see it so important towards an elective recovery programme, that we are looking to automate as much of that as possible. And what I mean by that as a starting position is using things like the Royal College of Surgeons national guidance on risk stratification, as in the prioritisation of patients. We can apply that against the cohorts of patients on the PTLs, even on free text and OPCS level, to at least group them into cohorts to then be basically. So the idea is to reduce the funnel so that the cohort that is put in front of a clinician to make the decision on is narrowed as much as possible through an automated process. And then that makes it much more viable and much more less heavy lifting. Now, this is new stuff. So, this is new territory, this risk stratification to this level and this magnitude. And obviously, it kind of has two changes, because you've got risk stratification for your most, and as you move through to your priority fours, it changes from risk stratification to longest waiters first. So in certain ways, one's going to have two approaches to this. You've got to do your risk stratification prioritisation in most urgent, and that needs to be a dynamic process that continues on. So wherever possible, software, or at least you need to set up a system and process on your PAS system that allows you to continually check and challenge that. And at the same time, you need to look at the tail end of this, which is your non-urgent activity, to determine your longest waiters first, so that when you do start scaling up activity, that you are drawing off those long waiters first. So, this is definitely a change from the classic 18-week RTT, where it's always in date order. This is much more about risk stratification. You can do it without software. We are doing it without software. It's heavier and it's a tougher route take, hence the need and our push to develop a software tool that will help automate that. So we're rapidly moving forward on that and testing it, and hopefully that will be available. But coming up with that is going to be critical for lots of organisations.
Thank you. And finally, where do you begin to start with trying to recover elective care performance? Where do they go for more information, Brian?
All right. Okay. So, here we go. So if I push this through here, so guys, this is a genuine offer out there, that please do come back to us if you've got further questions. If you just want to get underneath the meat, because a presentation is a presentation, but obviously, when I put out that slide of the 3 phases of implementation, there's a lot of detail behind that. and therefore, if you want to discuss how you get started, Wood for the Trees stuff, where do you get going, then do reach out for us for a further discussion. We're here to help, and we want to help. Hamish, is that it on the Q&A?
I think so, Brian. There's a couple more that we'll respond to. We've got people's email addresses, but I'm conscious that the hour is up. So I'd like to thank everyone for joining this morning.
Great. Thank you all for joining the webinar. And I hope that this is the first of a number of them. We want to continue to do this as we work alongside our NHS colleagues and understand and refine the challenges that organisations face, and actually in future ones, as I said, let's invite. We would like to see some NHS colleagues helping us on the webinar, helping inform this, so that we can support the NHS as best we can. Many thanks for joining us.